For today's episode, we have Dr. David Himmelstein. We're going to be talking about healthcare reform, Medicare for all. What's wrong with healthcare policy today? Where can we go in the future? But first,
there's no place to hide now that he's arrived. I'm saying he ain't playing now with this campaign. Bang, dang, it's in. Drew, come roll with the gang gang. Drew gang gang, that's who I hooked up with. Drew gang gang, that's who I hooked up with. Drew gang gang, that's who I hooked up. Yo, there's no place to hide now that he's arrived. I'm saying he ain't playing now with this campaign. Bang, dang, it's in. Drew, come roll with the gang gang.
hello, nerds.
Hello, nerds.
Dr. Himmelstein, welcome to the show. I have to thank Laura Lane, one of the Nerds for Humanity members, for recommending that we get you on the program. How are you doing today?
I'm great. How are you?
I'm fantastic. I'm really interested and looking forward to this conversation because obviously healthcare has been a topic on a lot of our minds with the corona stuff. But even before that, during the 2020 presidential election, and I guess I could talk about it in the past tense for the most part. During the primaries, we can say for sure, healthcare reform came up a lot. It's been a topic that's been discussed at length for many years now. And my understanding is that you've been thinking about healthcare and policy for a while as well. Can you give us a little introduction to who you are?
Well, I'm a doctor. I'm a primary care doctor by trade, and found early in my career that the healthcare system wouldn't actually let me do good work. So I got involved in trying to change the healthcare system and ended up spending really a lot of my time doing that. So I'm about 35 years into this now, and I early on just really came to the conclusion that what we needed was national health insurance, what's been called single payer, or more recently Medicare for all. Not the only fix we need to our healthcare system, but I think it would lay the foundation for what we need. And I should say at the moment, because of my age, I'm not seeing patients. I'm mostly a university professor teaching public health and helping my younger colleagues do research both at Harvard and at the City University of New York.
Right on. Well, you look like you could still be an attending, so you're taking care of your health. I'm glad to hear that. Before we get into some of the details, I should make crystal clear that this interview and frankly this whole channel is my personal project on my personal time. Anything I say here is my personal opinion. It's not reviewed, approved, anyway connected with my employer. So I just want to make that disclaimer. Now let's get into the details, David. Tell us a little bit about your decision, I guess, 30 some years ago, to get more involved with policy. I'm guessing, that wasn't an easy call, because when you're a doctor, you're working with patients one-on-one. That's very rewarding. You can see sort of the impact. Why wade into the kind of bureaucracy of policy and DC? It sounds like not a super obvious and attractive choice. Tell us about that decision.
Well, actually, when I was a resident in Oakland, California, at the county hospital there, we were getting a stream of patients who were refused care at private hospitals nearby and sent to us, often with really grave injuries. I remember one man who arrived with a skull fracture, and actually you could see brain through the wound in his head. He'd been cared for at a private hospital, but they did what we referred to as a negative wallet biopsy. He had no insurance card, and they shoved him into an ambulance and sent him to us. And we discovered he had not only the skull fracture, but a broken neck as well. And that was kind of an extreme case, but not that unusual for what we saw day to day at the public hospital there in Oakland. And that really led us to conclude we were seeing patients who were abused routinely And we needed to try and do something about that. So some of the other trainees and myself really started to do research on what the healthcare system was, what was going on around us. And one of the other things we noticed about this guy was he was actually insured, but he didn't have his insurance card with him.
Mm,
And it turned out that once they found out he was insured, the hospital that had refused to care for him at the outset demanded that he be sent back to them so they could make money off him after that. So I came to realize the healthcare system abuses both uninsured people and insured people in our system, and more and more I came to see that trying to do something about those kind of abuses was going to help my patients, not just today but tomorrow. So we actually collected a series of cases of patients who were refused care at private hospitals and sent to us. We published it in a major medical journal, and it caught attention in Washington while I was still a resident, and led to the law that says that emergency rooms need to stabilize people before they send them away. So early on, I had the experience that you can make some changes in this country. Not easy, but you can make big changes that affect people. We need much more change than that.
yeah, how long did it take from this story kind of getting picked up by the media to the folks in DC actually introducing legislation and passing it? I mean, that sounds incredible. Like, I mean, on the one hand, you're like, yes, that's how government should work. We see a problem, we try and solve it. The thought of that happening today seems just like it's a fantasy novel, like it would never happen. What was it? How did that work
Yeah, it
when it
hasn't
happened for
happened
you?
to me since then. Uh, so well, we when we published the study, we issued a press release and made an estimate of how many people nationwide were being affected by this, and it caught attention of Senator Edward Kennedy, Ted Kennedy,
Hmm.
who was the chair of the Senate Health Committee at that time. So he was in a position to do something about it. There was a Democratic uh, Senate and House and President, so it made things easier to get through. And I think in some ways saying that emergency rooms need to uh, not be sending away people who are in life-threatening situations is an easier lift than some of the other reforms that I've come to advocate through the years.
Yeah, I mean it seems like it should be a pretty bipartisan thing. I don't know, maybe I'm just becoming a little jaded this year, but I feel like even that would have difficult if we didn't have that today. Like I'm not sure it would be a quick bill to pass in today's world. Maybe it would. I don't know. I mean, on the other hand, like you can come full circle where now that hospitals have to provide stabilizing care, that also tie into the Affordable Care Act saying, well, then everybody should have at least a basic level of insurance because you don't want people to treat the emergency room as their free insurance and have some people insured and not, and everybody should kind of get some level of coverage. Or how did you see that happening?
Yeah, no, I think you're right that it in some ways helped open the way for discussion about what we need beyond that. So um, the emergency room has to stabilize you so you're not in life-threatening condition, but they don't need to go beyond that. And we now know lots of stories of people who, yeah, their lives weren't in danger, but they lost their sight because they had an acute problem with the eye, and that wasn't life threatening. And they got sent out with a note that said, "Go see an eye doctor." And by the time they did, they were blind. So um, uh, we know that it kicked off more discussion, and we've had several rounds of that discussion. I was around when Hillary Clinton and Bill Clinton tried to make health reform, and actually, I met with Hillary Clinton during that period and tried to convince her to go for something bold, and they decided on a much lesser reform. And of course, the Obamacare reform, which didn't actually get us universal coverage. There were still about 26 million uninsured even after the reform was fully in place. And of course, the Trump administration has whittled away at that. But that was a useful step. And hopefully it's a step to something much further during the Biden administration.
David, what do you say to people like, I'll give you an example. My family has representatives of both parties. And when I talk about healthcare reform with my mom, who is a staunch Republican, she always says, well, I don't believe in socialism or socialized healthcare. And, if you look at Canada, people have to wait 3 years just to get like an annual checkup. And, why do you think all the Arab sheikhs come here for healthcare? We're the greatest country in the world. We're not going to learn from lesser countries. What do you say to people who make that argument? Because it's not just my mom. I've heard it from other
Yeah.
Republicans as well.
Um, well, there's some of that's based on misinformation. So, in fact, no one waits for 3 years in Canada for a routine checkup. They have more primary care doctors per capita in Canada than we do, and for most routine stuff, the wait is, if anything, a little shorter there than here. And both in Canada and elsewhere, the health statistics actually say they're doing better than we are. So, their infant mortality rate, which was higher than ours before they started their national health insurance program, fell below ours and has stayed there. Their maternal mortality rate, the same thing. Their life expectancy overall is about 2 years longer than ours. And it's not just Canada, it's people in many other nations. Now, Canada spends only about half as much per person as we do for their healthcare system. So we ought to be able to have Canada Deluxe. And what we have is not Canada Deluxe, but a much more defective system. So, I mean, this has been looked at and detailed, and with some colleagues in Canada, we published a study looking at everything that's ever been published in the medical literature, comparing outcomes of patients in the US with those in Canada. And if anything, the Canadians do better than we do. And that's been recognized. I mean, what's his name? Paul, the senator, Rand Paul, when he needed his hernia repaired, he went to Canada to have that surgery at a clinic there that's the highest regarded hernia repair center in the world. And his spokesman said, well, that's a private clinic that Canadians wouldn't normally be able to go to. But in fact, any Canadian can walk into that clinic and have their bill paid, no, first dollar paid. And in fact, you don't even need an appointment if you're Canadian to go in there. So there's a lot of misinformation and misimpressions, but the data and studies actually tell us not only Canada, but many other nations are doing better than ours. Back about 1980, our life expectancy was middle of the pack among wealthy nations. So we were sort of similar to Canada and France and other nations. And now we're about 2 to 4 years behind. So we've fallen behind as we've made our system more market oriented. And I guess the last thing I'd say to your mother is, I think she likes a socialized fire department. That she likes the government to provide some essential protections for everybody. And the way we run our healthcare system is makes about as much sense as saying that the fire department should first ask what your insurance is before they take care of you, and should send bills every time they go to check out a fire. So I think we do have some, I wouldn't call it socialized, but public services in this country that everybody makes use of, and medical care ought to be one of them.
Yeah, that's a great point about the fire analogy, especially if the uninsured house starts burning down the rest of the neighborhood, then it's kind of like we're all in it. We're all going to be involved in some way or another. You may want to just prevent that first house from burning down and spreading all over the place. What do you say about the you said you did some of your work is with Harvard Medical School. We're reading about Moderna, like these kind of groundbreaking research and innovation that is happening in this country. And there are wealthy, billionaires from China that come here when they need their heart surgery or wherever, for cancer treatment, whatever. How do you reconcile the fact that in a lot of ways, America is the leader in medical science with what you're saying, which is like, yeah, but we're not taking care of our people.
Yeah, well, America's leadership in medical science is mostly due to the National Institutes of Health that funds most of the basic research. So, yeah, Moderna and some others do some terrific things, but the basic stuff that leads up to those product development pieces actually largely comes from our publicly funded research. And to be honest, though America is a great research innovator, on a per capita basis, we're no better than many other nations. So, Switzerland actually produces more scientific research per person than we do, and Sweden does as well. And major innovations like the CAT scanner and other imaging devices come out of England. So we do our share, but probably not more than our share compared to other nations when it comes to basic medical research. I guess the other thing I'd say, this comes from personal experience. My father was a member of the team that developed cardiac catheterization, which is now used all over the world. And the leaders of the team won the Nobel Prize for it. And no one on that team actually made money from that invention or thought they were going to make money from that invention. And they were all stimulated to do that research because they wanted to do that kind of research, not because there was a commercial incentive for it. And I think if we are willing to fund the research and development through our NIH or other means, there are plenty of very smart people prepared to do that work.
Yeah. When you were watching the primaries, there was debate within the Democratic Party about how best to address the problem of healthcare, and there was a range from, I guess, Bernie of Medicare kind of for all the way to, I guess you could say, Biden, which is, hey, let's make the Affordable Care Act better. And I'm curious, do you see this like an inevitable kind of march towards a single payer system, or do you think, well, no, actually, you may not have to go full single payer. You can actually get away with competitive private system as long as there's more kind of basic insurance options and maybe a mandate or something like that?
Well, the big problem with saying we're going to put patches on the current system is it's incredibly wasteful. And a lot of that waste is the bureaucracy of maintaining the private insurance system and having, Cleveland Clinic says they have 200 million different bills, different prices. And that's an enormous expense, maintaining that kind of complexity in our healthcare system, which having hundreds of different private insurance plans really requires. So again, going back 30 years now, we've been doing research on what's the cost of maintaining our competitive, so-called, though it's not really competitive, for 40% of Americans live in regions of the country where we can't have more than one hospital or more than one specialist of a particular type because there's not the population density for it. But to have a market-oriented system, we're throwing away about $600 billion a year. So our insurance companies, for every dollar we pay in, we only get about 86 cents worth of care out, and the rest goes for their paperwork and bureaucracy and profits. Canada runs for less than 2% overhead, and the difference between 2% overhead and 14% overhead is something like $200 billion a year. And then the flip side of that is every hospital, every doctor's office has to deal with the different billing requirements and paperwork for the way our insurers insist we have to do to get paid. So, this came home to me many years ago. I was visiting a friend who was hospitalized at a big hospital in Toronto, and 900-bed hospital there had 3 people in its billing department. and their job was just to send bills to Americans who wandered across the border. Because
Oh.
Canadian hospitals, to go back to the fire department analogy, they get paid like a fire department does. They get one check a week or a month for their entire operation, and they don't bill for individual patients and every aspirin and Band-Aid tablet. And when I got back to Boston, I again spent 30 years at Harvard. So worked at a 900 bed tertiary care referral center there, Mass General Hospital. And at Mass General at that time, there were 352 full-time people in the billing department, not because they were inefficient, but because that's what you had to do to get paid. And since then, the billing department at Mass General has exploded and much larger than that. So uh, the simplicity of national health insurance, where you can say, the CEO of Mass General knows on January 1st what their budget is going to be, but they collect it drop by drop and aspirin by aspirin, in sending hundreds of millions of bills, and that's enormously expensive and inefficient. So, long-winded answer, the problem with putting a patch on the current system and leaving our complex network of different insurance plans is we throw away about $600 billion that we could save and devote to increasing care. And that's not just my estimate. There was actually a research study published this year in the Lancet that said that the Biden style plan would cost about $630 billion more to deliver universal coverage than a Medicare for all type plan would cost. So I don't have necessarily a moral difference with putting a patch on the system. And if Biden can take some steps to get better coverage and more coverage, that's great. But to really solve this problem, not just for uninsured people, but to hold down costs, we need to make the system more efficient. And I think the only way to do that is national health insurance.
What's the path to getting there? Because it seems like even if someone on a whiteboard says, "Oh yeah, national health insurance, single payer," I buy that. That's probably has some advantages over the current system, and there's some pros and cons, but ultimately that might be the most efficient approach. We have the system today. It's very complicated, as you mentioned, with so many different stakeholders and trillions of dollars spent every year. How in the heck do you change that monster other than doing these incremental bills? Like, how would you even
Yeah.
do that?
Well, ultimately, you need to pass something through the Congress. I mean, I'm not a soothsayer, so I can't predict exactly how we'll do it. What I can say is that in my lifetime, I've seen lots of unpredictable major advances happen. So, back when the Massachusetts Supreme Court ruled that gay marriage had to be legal, we came out of the blue. We were tremendously surprised by that change, and we've had other major social changes in this country. This one is going to upset a lot of carts. But frankly, I don't think there's any other way we can do it other than to upset those carts. On the plus side, the surveys are showing that more than 60% of Americans favor Medicare for all. And if anything, that's been growing. I thought there was a really striking graphic on election night that was on Fox News that 72% of people they surveyed in exit polls said they wanted the government to run the health insurance system. So that's not just Democrats. It's like 80% of Democrats, but it's even surveys are showing something like 30% of Republicans. So I think this is potentially a bipartisan issue. The problem with it is it's a bipartisan issue that says to the insurance companies, you're not doing anything useful for the enormous amounts of money we're paying you. We're going to stop paying you that money, and that's a tough lift. But maybe there's a state that does it and shows that it works. I mean, that's how it got started in Canada. Is one province put together a program, and it worked well there, and the rest of the country said we want that as well. And there are proposals at the state level to do that. There are bills in Congress. We have the majority of Democrats now signed on to the Medicare for All bill that's in the House, and about 20 senators signed on there in the Senate. So we've made progress. When I started this, people used to say, we started a group called Physicians for a National Health Program, and a reporter said to me, "Is that a sister organization of Furriers for Animal Rights?" But majority of my colleagues now support Medicare for All. Surveys are showing that.
What state do you think is set up to do that? Is it Massachusetts, or is it some have you seen a state that you think has an appetite to give it a shot?
Um, well, there are a couple things that would go into that. One is the political wins, and the second is the practicality. So a state that doesn't have too many people going across the borders every day is
Mhm.
probably better set up to do that. And Massachusetts has a problem that way.
Yeah.
Uh, bills have actually passed the legislature in California and in New York. At least one house of the legislature in each of those. So there's a fair amount of political appetite for it in those states and in Vermont and at a couple of other places. So we've seen several states where it's made a lot of progress, but hard to say where we'll make the breakthrough. I know there's been a strong movement for it in the state of Washington as well, and maybe geographically Washington would make some sense.
Yeah. Yeah, I guess Washington, um, you would love like Alaska or Puerto Rico or someone that could be really contained. I would not be surprised if one of these states actually pulled it off, that it would actually affect where people wanted to live. Like if you're graduating from college and you know that this state has single payer, and you don't have to worry about fighting your insurance company every time you need to get some treatment, and ideally like it's working and the incentives are well aligned. Yeah, you could see it's spreading pretty quickly if it worked well.
Yeah, and I think
You
it
know.
would actually not just attract people potentially, but businesses as well.
Yeah, totally.
Not only the hassle of insurance, but particularly, I mean, there's more healthcare than steel in an American automobile at this point. It's an
Mhm.
enormous cost for U.S. industry, and it's one of the reasons why um, other automakers have a competitive advantage over U.S. firms. So I think for business, this actually does have considerable attractions.
Yeah, I started a company, oh, let's see, that was about 7 or 8 years ago, and it was a small business. There's only like 10 or 12 employees, but I spent so much time trying to understand the healthcare system, picking the right plan for our company, and then spending a lot of our precious capital on employee healthcare, because I wanted to make sure everybody was covered. But then every year, the amount of the premiums were going up at a really high rate. And at some point, the investors were saying, "Hey, you don't have to give your employees like the Cadillac plan." But part of me was like, well, it's not. I mean, we call it the Cadillac plan. It just means you want low copays and you want to be able to get care and not have to have like these very low kind of ceilings on how much care you could have if you got really sick. I mean, we call that here a Cadillac plan. But I agree with you. I think a lot of business owners would prefer not to have to deal with that. I mean, it's so painful. Every few years, you got to kind of pick your new provider and run all these numbers, and invariably the numbers are going up higher than inflation. Which reminds me of another question I had for you, David. You look across other countries that do have perhaps more efficient structure and systems, but their costs are going up at higher rates than other goods and services as well. Do you think that's inevitable? Like, what's behind why healthcare keeps costing us more and more?
Yeah, well, there are a couple of reasons for it, and one is that industries that where it's very hard to replace labor with tech tend to be more expensive. A guy named William Baumol was still is an economist who noted years ago that you can make a TV set for less and less as you automate the production, but it's very hard to increase the efficiency of a string quartet. So healthcare, about 50% of healthcare costs are labor costs, and it's very hard to wring efficiencies out of that. So relative to other things in the economy, labor intensive services tend to go up in cost. That's one thing. But the other thing is that we've had incentives to increase the cost, but no incentives to decrease the cost. So for our insurance companies, they take 14% off the top, no matter how much they pay out. So actually, though, in any one year, they'd like to restrain how much is spent. Overall, their take gets bigger as health spending goes up, and every other actor really in the system tends to have the same incentives. The more they take in, or the more they do, the more they profit. So, um, you know, back in the 1950s, there was a projection that the cost of caring for polio victims would bankrupt America because so many people would need respirators to support them for their lives. And it turned out that a simple tech polio vaccine prevented all of that and cut costs. But we don't have incentives generally for our drug companies to produce drugs that save enormous amounts of money. Um, and that was driven home, I think, best to me by a Goldman Sachs analysis of drugs that cure hepatitis C. And he said that's a problem because you take the drug for 6 months and you never need it again. And then you stop infecting other people, so you cut off your market. So infectious diseases and preventing disease is actually not a good investment for the long term, and companies shouldn't be focusing on that sort of thing. So we need to change the incentives, and under a commercialized system, we've had great difficulty doing that.
Yeah, that is a very disturbing analogy or example with the Goldman Sachs summary. But I mean, as a business person, I totally get it. That, well, if you're an investor, do you want to invest in the company that's going to cure some chronic condition, or do you want to invest in a company that's going to kind of mitigate the symptoms and have an annuity basically until the person expires? I mean,
Exactly.
if you just look at the balance sheet, like, well, the second one sounds like a more successful business, and that's the way that the incentives are set up. What do you think? Now, a counterpoint to that would be, yes, that's an example where the free market is a little weird. Now, someone could say the free market also would introduce another company that isn't in this space that says, okay, well, I'm not making any money here. So if I can cure this chronic condition, I'll still make a ton of money. I don't care. And I'll kind of, disrupt the industry, and everybody wins. What are your thoughts on kind of the good old competition market solving these problems for us?
Well, I think there may be a place for some market incentives in the system, and I'd love to see that. I'm, as I said, 35 years into being a doctor, and I haven't actually seen those sorts of things. And we've seen the reverse. We're not developing new antibiotics, basically because there's not a long-term profit to be made from constant sales of those. And for many other conditions, we've got cancer drugs that are by and large enormously expensive and need to be taken over long periods of time. They're not quick cure and you're back to health kind of things. So um, I'd love to see it. I haven't seen it yet, and I'm skeptical that we're going to see large scale disruption of that kind in the near future.
Let me channel my Republican side of the family again. They would probably say, "Oh, this all sounds fine, but look, there's a reason you use FedEx and not the USPS, or there's a reason why, so many government programs are, kind of littered with waste and fraud and abuse and inefficiency, and they don't have an incentive to give you good care. I'll trust the profit motive over, government bureaucracy. What's your sense of that?
Well, Medicare for all or national health insurance, we're not saying government actually runs the healthcare system. What we're saying is vast majority of hospitals and doctors remain private, just as they are today. But the insurance system is a public system. And again, FedEx and UPS use public roads and lots of other infrastructure that we understand needs to be there for everybody in the country. And if we think that everybody needs to have health insurance and that we need to have an efficient network of health insurance, so not, roads that run parallel to each other and have different stoplights, some are green for go and others are red for go. That's more the analogy to health insurance is let's put in place the infrastructure so that the people actually delivering the care can do the work. And again, what we're proposing is, as in Canada, hospitals remain almost all private hospitals. Doctors, in fact, are much more in private practice in Canada than they are in this country. But let's have insurance for everybody. And let's make sure that insurance system is more efficient. And we have examples not just from Canada, but from this country as well, that the insurance systems are more efficiently run in a universal public program. So Medicare, like Canada, runs for 2% overhead. And again, that's about 1/7 the overhead of our private insurers. So really what we're saying is transform the insurance, not the providers.
Yeah, that's a nuance that I don't feel is conveyed often by advocates of Medicare for all. I feel like single payer is not equal to single provider. And you could have providers compete for your business, compete for your patronage as a customer. You could have them try and out innovate each other. You don't have to have a million different private health insurance plans making them jump through hoops to get that. Um, do, do you feel like that's kind of landing? Do you think people understand, are picking up on that difference? Because that would address a lot of the classic kind of Republican concerns about Medicare for all. Because when they hear it, they think, oh, they're going to go to the state hospital and there's going to be one of them. And there's going to be just these long lines, and all of your doctors are going to get fired, or they're going to start wearing gray suits and, be on death panels and everything.
Yeah, no, I think you're absolutely right that the impression that's been conveyed is that we're going to, we're going to have a Soviet-style healthcare system under single payer, and nothing could be further from the truth. In fact, when we talk to colleagues in other countries, what we hear is they're much less hassled by the insurance systems in their countries than we are here, and there's much more latitude to do what they think is the right thing in practicing medicine than we have today. I mean, Canadian physicians, and we meet all the time, the American College of Physicians, which is the organization of internists, has chapters in each of the Canadian provinces. So when there's a meeting of internists, it's across the border. Except today, I guess, when we're not allowed to cross the border. But when we meet with them and they hear stories about the way insurance companies are interfering with care, they say we would never put up with that kind of thing. And the paperwork that's inflicted on doctors in this country is just almost unheard of in other countries.
Let's talk about the big elephant in the room. I mean, we can't discuss public health and public policy without the current pandemic. Do you think are those orthogonal? Like, does the single payer argument have anything to do with how we handle national pandemics, or is it like it's related, but they're not really strongly tied to each other.
Well, I think there are important ties. One is because we've gone more and more to a market system and said government shouldn't really be playing much of a role. We've let our public health infrastructure decay. So since about 2000, we've lost about more than 20% of our total public health workforce because the funding for public health, and there's no insurance company that wants to fund the public health agency that does things like contact tracing and all the other stuff that actually is critical for fighting pandemics. The public health infrastructure has decayed, and we've lost professionals and frontline workers in public health. So that's one thing, is that really falls between the cracks in a commercial, more market-oriented system. A second is that because we've had such deterioration of health status, and we've actually had worsening health in the United States over the last, not just during the pandemic, but for the decade or so before the pandemic. So the number of people with diabetes who have their diabetes under control, the number of people with high blood pressure who have their blood pressure under control, we're going backwards on those things. And that's the failure of our healthcare system, which sets us up for people to be really vulnerable for serious illness. And the third is we don't have a rational distribution of the resources to care for people once they're sick in the pandemic. So what we've got is the hospitals driven by what's profitable rather than what's needed. So services like ICUs are located where they're profitable, and that's often in communities with the lowest needs for their care. In New York, we saw this really played out in quite striking ways. The parts of New York City that had by far the highest caseloads had by far the least ICU beds. And that's even more extreme in rural areas of this country. And we're now seeing that hit hard as rural areas are being hit by the pandemic. So we were vulnerable because of the decay of public health infrastructure, because the health of the population left more people likely to get seriously ill when they were infected, and because our healthcare system was ill-equipped to deal with the results of the pandemic once it began to hit. So I think those are the ways in which we were ill prepared. We'll see as we hopefully roll out the vaccines whether our healthcare system can rise to the occasion of actually distributing those vaccines. I worry about it.
Oh, do you feel like the incentives will be for the providers or the infrastructure to focus on the higher income areas, or do you think that we've got that figured out so that it'll be uniformly distributed?
Well, a lot of the infrastructure is focused on higher income areas that are relatively low rates of COVID and low risk for COVID. That's one thing. But also, with the testing, for instance, even after the government said testing should be free, what they didn't say is, and after you get a test, if you need medical care, that's free. So if your test came out positive, you were stuck with a big bill in most cases. And what I worry about is that the vaccine may be free, but actually getting it injected into your arm may not be free. So that was true of some of the testing. Is yes, the test itself was covered, but the cost of getting someone to put the swab up your nose and have the personal protective equipment to make that safe for them, that wasn't covered for many people. And actually delivering the vaccine may not be free for a lot of people in this country. And if we have side effects from the vaccine that drive people back to the doctor, that almost certainly isn't going to be free. And not only the uninsured, but a lot of people, if you have a $5,000 copay, it means you could incur a big out-of-pocket hit before your insurance even kicks in.
Yeah, I read some reports of some states are basically pre-ordering vaccine and prepaying, cutting deals basically, to get access earlier, even if those states do not have the worst infection rates. but they may have the most money, or governors who are, trying to get in front of it. And you wonder, like, well, okay, this is a national problem. Like, you could argue there's a different way to allocate and to do it based on where you see the most kind of problematic spread or whatever. But I don't think that's how, it doesn't sound like that's how it's rolling out.
Yeah, and I guess one maybe extreme example of that is the Pfizer contract with the Project Warp Speed. I understand includes a clause that says that Pfizer executives are at the front of the line for the vaccine if it's ever developed. So those are not the folks with highest needs, and they're not the ones who maybe we should be giving priority to. It's not just the executives, but all the members of their families and the subcontractors' executives as well. So again, maybe that's a small number and not terribly important, but I think it's emblematic that we need to get the vaccine to where it's needed most and where it's going to do the most good early on, and not prioritize based on who's got the most money.
Yeah, I mean, you could say, like, look, I live in California and in Silicon Valley. I conduct all of my business remotely from my home office. I probably am not at super high risk of contracting because my job doesn't require me to be in person. You could argue I should be like almost towards the very end of the line, and that someone who's like a waiter at a restaurant or works in the service industry, that's lower income and can't just Zoom for work, you should argue they should be at the front of the line. But I don't think that's how it's working. I think it's like first responders and then the rest of us. Maybe by
Yeah.
age, certainly for older people they might get but then there isn't anything that I understand about, oh, like your risk level based on your job. But you could argue that should be a factor.
Yeah, and I mean, and to use your analogy earlier on about you don't want the house to burn down because it could catch others on fire. Even if the vaccine is 95% effective, it still leaves you a 5% chance if you're exposed. And you want that waiter and the other frontline workers who you
Yeah.
might encounter to actually be vaccinated and be protected. That's how we're going to get the pandemic under control.
Oh yeah. I mean, frankly, I would pay them to get vaccinated because I just feel like it's the return on investment for the country is so high that it's in everyone's interest to have broad vaccination from folks who are in jobs that interact with a lot of people. And I don't interact with anyone. I'm just sitting here in my home office all for the last 9 months. But the dude that's like, making the burgers to go, he's coming in contact with a lot of stuff. All right. Well, let's get into some audience questions before we wrap up. Do you still have a few minutes to talk, David?
I do.
Okay. Before we get to the audience question, just for clarification, you seem like a very reasonable, contemplative guy who's been in the health industry and health field for decades. You're a licensed doctor. You attended to patients, and you believe, just to be clear, that COVID is a real problem, that it's not just the flu. And do you believe that people should be taking steps to mitigate the spread of the virus?
Oh, absolutely. I don't think there's any question there. And um, I actually have a daughter who's been working in an ICU, a doctor working in an ICU in Boston, and has seen lots of people dying from this disease. And there's no question that there are things we can do to stop the spread even before the vaccine. We're not doing them, and we need to.
Okay, so you support the use of masks and social distancing?
Absolutely.
Okay. I know it sounds like a crazy question, but I'm on social media enough to know that there's probably at least a third of the country that they do not accept that. And they believe that it's a political kind of effort to discredit the current president. But I'm glad to hear your thoughts on that, and hopefully other people will think about that more. First question from the audience. Do you think there's some resistance to reform because of the jobs that would be lost. I just looked it up. Like the private insurance industry is like millions of employees. It touches trillions of dollars. That's not naturally characteristics of a space that's eager for change and will embrace change, especially if they become obsolete. Like, well, if you have single payer, then why do you need a health insurance company?
Yeah, that's absolutely right, and it's one of the reasons why we pushed very hard that the single payer or Medicare for all bills in Congress needed to include funding for job transition for health insurance workers, and universal basic income would be very helpful there. You wouldn't need a special fund for those folks. Now, most of the people working in billing and insurance, and we estimate there are about 1.5 million people doing useless work in that space. Most of them are relatively low wage workers. Now, there are some folks who are really the leaders of the opposition. My favorite is a former colleague of mine at Harvard, Jack Rowe, who was a really terrific geriatrician. He went on to be the CEO at Aetna. And while he was at Aetna, he made $225,000 a day. So we're not going to be able to find comparable work for Jack. But most of the workers for Aetna, we need to find useful things for them to do in our society. And we didn't say when automobiles came along that we needed to keep all of the people making horseshoes fully employed.
Yes. I guess the rub is the current horseshoe makers have a lot of resources to fight the development of the automobile and say that it's all these terrible things. And their voice is being heard so far in Congress and in the White House.
That's not only a lot of voices, but a lot of money to get out that message. So that is the biggest problem. And again, even though 60% of Americans favor that kind of reform, if you look at the flow of money, the industries that would stand to lose are some of the biggest funders of both the Democratic and Republican parties. So that's a big thing to overcome. It's been overcome in every other nation that's a wealthy nation. Taiwan switched to single payer system about 14 years ago, I guess now. It's been a spectacular success there. It did pretty much wipe out the health insurance industry in that country, but they're much better off for it, and people recognize it.
Yeah, totally. Next question from Laura, who helped set up this interview. Thanks again, Laura. Is the public option an effective way to transition to single payer? You talked about, well, you don't want to patch up a broken thing, or you can only get so far with these patches. Is the public option a worthy patch?
Well, I worry about the public option. It might do some good, but I think a lot of it, of that good, is coupled with the fact that it's likely to become really a high risk, low profit pool that helps the other insurers out. We've seen that in the Medicare program, where we have the traditional Medicare program, which is a public option that competes alongside of private Medicare Advantage plans, where government will pay your premium if you want to switch to those plans. And what's happened is the low-cost, profitable patients have been enticed into switching to those plans. And once you get sick, the plans make it uncomfortable for you to stay. They have enormously high copayments for cancer drugs. They don't give you home care when you need it. And they say, they implicitly go back to the Medicare, traditional Medicare, the public option, when you're unprofitable. And the estimate from the official agencies that look into this is having the private plans competing with traditional Medicare has driven up Medicare's cost by about $1,000 per person. So I fear that a public option becomes almost a way to subsidize the private insurance plans by taking the unprofitable patients off their hands. So if it gets some people coverage, I'm all for it. I don't think it's a way to take a step towards single payer. I fear it's not, because it ends up as a high risk, low profit sidelight.
That's a really profound point that I don't know a lot of people have spent a lot of time thinking about, which is if you do the public option, and to your point, if all the private insurance companies kind of like push their most expensive patients to the public option, because frankly, if I were a health insurance company, that's what I would do, just because of the numbers, right? Then what will happen is a few years later, when the next round of legislation comes up to discuss single payer, the argument will be, look, Medicare is a mess. Medicare is extremely inefficient. Their cost per patient is way higher than the free enterprise market insurance. And that's example of why it really is the USPS, and it's like Amtrak, and it's trash. And it will be important for as many of us as possible. It's kind of like the counting of the ballots. Like, we all saw that the mail-in was going to get counted later, and we knew the chart was going to look like Trump won early and then Biden would catch up, and we knew people were going to say it was stolen. And some of us were talking about this for months and months. This is another debate that if we put on our Nerdstradamus hat, which is if we have a public option, I guarantee you 2-3 years later, the Republicans will say, see, that public option is so expensive. And we're going to have to explain, well, that's because the private insurance companies dumped their most expensive patients into the public option to protect their bottom line. It's not because the public option in and of itself is somehow terrible. But that's a hard thing to explain in kind of the age of Twitter and bumper stickers.
No, you're absolutely right, and I like the way you've put it. I haven't made the argument that way, and I'll learn something from you.
Well, I appreciate you bringing it up because it's such an important point. Here's the next question from the audience. Someone was asking, hey, if why are people being charged for COVID tests if testing is supposed to be free? I've heard this a lot. I mean, my kids, their school requires them to get tested weekly, but I pay for them out of my pocket for it. And I'm wondering why aren't there just free COVID tests for everyone?
Well, there should be, but there aren't, because the laws that have been made say that they only need to be covered when it's, quote, medically necessary, and the insurance companies have decided what's medically necessary and what's not. And as I think I said before, the test itself might be covered, but the cost of getting the sample may not be covered. So once the sample is in the lab, that cost might be covered, but the cost of having a nurse or a doctor actually obtain the sample, that's a separate question.
Yeah, got it. Laura has another question, is like, well, what if you just have strict government regulation of costs, but you keep the private health insurers? Any thoughts on that as an approach?
Yeah. Well, there are several countries that basically do that. They have incredibly stringent regulations of private insurers. Switzerland, Germany are like that. But their insurance companies are really unrecognizable for people who are used to ours. So in Germany, they've got dozens of different insurance companies. They all pay exactly the same rates. They all are required to contract with every doctor, every hospital in the country. If one insurance company accumulates too many high-cost patients, they get subsidies from the companies that have fewer high-cost patients, and the government oversees the whole system. But that's a system that's in some ways as different from our private insurers as a national health insurance program would be. We've studied those things a little bit as well. They're not as administratively efficient as going to a single public insurance plan. Germany has that kind of system because they started down that road in about 1890 and evolved to that system. But it works pretty well there. They're willing to spend, it would be something like an extra $100 or $200 billion over what a fully efficient public insurance system would cost. But as I say, uh, it's nothing like our private insurance plans in this country. In fact, in Germany, all the health insurers in that system are required to be nonprofit, and their boards are made up half of employer representatives and half of union representatives. So imagine taking, Cigna or Aetna and saying to them, by the way, you're going to be nonprofit starting tomorrow, and half your board is going to be union people and half are going to be employers, not the boards that you have today. So you could construct a system that might work using that. I don't think it's any easier than moving to a Medicare for all.
Yeah, as someone who lived in Switzerland for the last 4 years until this summer, I can definitely say that when I got there, a couple things happened. One was they were very strict about, oh, you need to pick your insurance plan in the next 30 days, or like you're going to get fined hugely. Basically there was a mandate that everybody has to have health insurance. So that was interesting because oddly enough, my mom had moved with us too, the Republican, and she was saying, "Oh, that's good because then everybody's responsible." And I said, "Yeah, Mom, that's basically Obamacare's mandate." And she said, "No, no, 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 that's very different." But anyway, my political conversations with my mom are always spirited. Then the second thing I noticed was when I was picking my plan, I was assuming, like when I was picking plans for my employees and my startup many years ago, there would be this range of options, and you could go for like this really cheap option, or you could go for the Cadillac option. Turns out there wasn't really a whole lot of difference. Like, oh, the premium would be like they were within a few percent of each other, and the amount of coverage was really almost virtually the same. And I asked the insurance broker, like, what is going on? Like, why isn't there more of a range? And they basically explained, well, we are required to cover your annual check-in. We have to take care of you if you get in a car accident up to a certain amount. Like, so we can't negotiate. There's not going to be a lot of variability. And their argument was, but this is probably in your interest because you're not going to buy something that you think gives you coverage, but really doesn't, which is probably what, happens to a lot of us over here. So yeah, it's been always fun talking about these nuances, David, because I'm hopeful that people hear this conversation, share it out, like it, so more people can kind of get into the details, because for you've been studying it for decades. A lot of people have not, and hopefully a more informed population and voter kind of participation will result in our interests being advocated for. Before we wrap up, Dr. Himmelstein, are there any other topics or call outs you wanted to make? It's been a real pleasure having you on the show.
Well, I thank you for having me, and if anyone wants to get in touch with me, I'm happy to answer more questions. There are some great organizations that are pushing for Medicare for all. Public Citizen Health Research Group is one of them. I work with that. Physicians for a National Health Program group I started 30 years ago or so. National Nurses United, largest nursing union in the country. So plug into those and many grassroots organizations around the country, and we certainly need much more work from the tech community to help us out. We're primitive. So thanks for having me.
Thank you, Doctor. With that, we're going to say goodbye, nerds.
Goodbye, nerds.